A warm welcome to one and all. I hope I am audible to everyone, right? Am I audible to everyone?
Yeah, I hear you. Yes.
Okay. It gives me an immense pleasure to stand here and to talk about the update of improving quality in pediatric cardiac surgery, where we have come across wonderful thought-provoking talk by Professor Pia and Kenyalang, Ms. Mpai Pan, and the wonderful presentation which just came across. So as we are going to focus on the updates, I'm going to revamp all the things which has been talked before. So it will be a short and a revamp session of all the talks which you have seen before. So what I'm going to talk today is the difference between adult and pediatric, the circuit which is needed for a pediatric surgery, oxygenator selection, what are the cannulas and how the technology has improved, what is the best myocardial protection strategy, and how a thermal management can be planned for a pediatric cardiac surgery with the cerebral protection and also goal-directed perfusion, which is just a revamp of today's whole topic. As I would like to throw light saying that all our pediatric cases are complex in nature, anatomically and also physiologically it is challenging, because all the pediatric infants are underdeveloped organs, and it is always, we should make sure that we should not think that infants or pediatric are not small adults. Why? Because the circuit which we are going to select, the hemodilution factor, the access, the cannulation, what type of surgery which we are going to undergo, and what strategy we need to plan has to be pre-decided by the entire team. I just want to go inside. What is the difference? I would like to enlighten and show this as pediatrics are not mini adult, because the priming volume of a pediatric or a neonatal blood volume is considerably 3 to 4 times more than the foreign surface area which it is going to roll on. And also, I would like to say again that the pediatric total metabolism is different and the organs are still immature. Just to understand, if you take a 5 kg patient with the blood volume constant, the total blood volume of the patient is going to be 425 or 450 in roughly. But while our priming volume is going to be almost 1200, which is the entire circuit itself. And even if you're going to use a miniature circuit, you can bring it down to 1000 ml, which is almost double the blood volume of the patient. Whereas in adult, take an example of a 60 kg patient with a blood volume constant as 65, the total blood volume of the patient is going to be almost like 4 liters, that is almost 4000 ml, while our priming volume is just 1600, and even it can be brought down by RAP and MAP. So we need to see that what constant and what is the weight of the patient and how we are going to calculate and how we are going to plan it across plays a very important role. As a pediatric perfusionist, I would like to make each and everyone in this forum to think and always have these facts in your mind. Number one, the pediatric circulating volume is much smaller. The oxygen need for the tissue is much higher than any adult. And we need to know that the vascular beds of pediatric and neonates are very sensitive. And that's why we need to focus on the oncotic pressures. We need to focus on the priming volume. We need to focus on the circuit, and all those things is much needed and much appreciated. And not only that, the thermal regulation, what strategy we are going to follow. It is an alpha stat or a pH stat. If you're going to cool, how much you're going to cool, and what are the plans which you have, makes a very important thing as such. And the ischemic tolerance, this is where GDP plays a very important role, where how much is the tissue need, how much is your oxygen delivery, what is the oxygen extraction ratio. All those things plays a very vital role in pediatric perfusion as well. So, and added to it, it is not like an adult, a simple mitral valve or a simple, CABG where it is the cannulations and it is a routine day in and day out. While in pediatrics, it's really complicated, where you will have lots of aortopulmonary collaterals, there'll be lots of blood surging in, and that is why usually in pediatrics and adults, we always used to think of higher suction or cooling down the patient to profound hypothermia. Okay, going to the circuit. Why do we need to focus on the priming solution, which was already spoken before? I just wanted to cut short and make it in a nutshell. We use Paediatric as a common prime for pediatric circuit, and we use plasma also. Why do we do so? It is because to reduce hemodilution. As I said, and as I showed an example before, it is almost double is the dilution of a pediatric blood volume, or triple. So we need to bring it down. So what we do, we are cut shorting the crystalloid prime, and we are introducing the Paxil and FFP to the prime, because there is a dilution of your coagulation factor, and we need to compensate the plasma protein as well. That is the most important thing. Added to it is albumin, which was elaborated before, and I would like to throw some light on it. It is for the oncotic pressure and also to make the perfusate to the required volume so that there is no fluid shift inside your cellular and also in your tissue level. As I told, pediatrics have high affinity towards, because your capillary beds are very sensitive and capillary leak can be very much also. So hemodilution and oncotic pressure also needs to be taken care of. And adding an albumin to your circuit can also help. It can coat your circuit, it can prevent platelet aggregation, increases your platelet count postoperative in a higher rate. Added to it, mannitol as a scavenger and also osmotic diuretics. Again, there is a very big debate going on whether mannitol can be added in prime or not. And the debate is still very long. It is not concluded. There are many centers which has totally taken off mannitol in the prime as well, but having a very good results. Bicarbonate as buffer, steroids plays a very important role where it provides a membrane stability in reducing the fluid shift and reducing the inflammatory response as of like your cytokines and all those things. Aprotenin and other drugs is also used as in the prime. And keeping the calcium to the lowermost is very well concentrated until cross clamp. And once cross clamp is released, we generally see that the anesthesiologist gives calcium to kickstart your heart, the pediatric heart, to pump again. So, as I was talking about the circuit, the tubing, the only aim here is to minimize the prime. Whatever prime you're going to add through, whether it is going to be a crystalloid, whether it is going to be a blood prime, albumin, all those things. But as a perfusionist, you and I has to focus on minimizing the priming and also to make sure that we flow adequately. And you need to keep in mind that these tubings are going to be smaller in size, not like a 1/2 inch or a 3/8, why it is going to be an entirely small tubings with quarter and 3/16, where your line pressure is tend to be higher. And also this can have a higher stress level to your blood components. And if it is a mix or a VAVD or a robotics, we need to make sure the appropriate levels and strategy management plays a very important role as well. As I told, coated circuits are very welcomed and it is now available in the market, and that is the update for this. This is an insight which shows that how much will be your volume for prime and also how much maximum flow which we can achieve with the maximum pressure drop. Now you can see that in a 1/8 we can have a maximum venous drainage of only 300 mL, while in 3/16 we can have up to 500 to 600 mL of venous drainage, and also we can flow up to 0.8 mL, that is 800 mL of positive arterial flow is possible with an accepted pressure range. And these will be a rough tubing selection for the weight range of 0 to 3 kgs, which is newborn, and for 3 to 8 and as such, which you can have a enlight on it. Miniature circuit is the update over here because the world is moving towards, and I have seen in a center in Germany that the total priming volume of a pediatric surgery was as low as just 80 ml. Just 80 ml was the priming volume of the oxy. Don't ask me how, that is what they do, because with the help of the mast pump, with the help of the smaller circuit, VAVDs, and autologous priming, wrap, and all those things, they have reduced the priming volume by miniature circuit as well. And I can say that it helps the patient's outcome. The morbidity and mortality is reduced in a considerable level. Coming to an oxygenator, as we all know that oxygenator is a vital role in a pediatric or any type of CPB. An oxygenator selection lies on the perfusion. So if I ask you which oxygenator is best, and all of us have our own preference, but I would like to emphasize that choosing an oxygenator wisely for the case which you are going to do is the technological update, and that is the most important thing which is required. So as we all know, in the market, we have hollow fiber oxygenators, which is widely used. And now we have coated circuit. Whatever is you need to select with the best coated circuit, which can mimic our endothelium so that the platelet aggregation can be brought down, complement activation can be brought down, and the WBCs and the interleukins level should be maintained to the lower level. And all those things has to be completely taken care of with what type of coating we are going to use. And also, how are we going to bring down the priming volume? As I said, is just an integrated oxygenators. Just wanted to show that there are a lot of oxygenators, but I would like to enlighten or show something here is always focus on what is the static priming volume, what is the maximum flow rate, and what is the surface area. Because as I told you before, the hemodilution in pediatric is way so higher, and we need to focus on the prime, the rate of flow, and the surface area. How much we are going to minimize it is going to have an effect on the patient outcome as well. As I said you before, nowadays we have integrated components because arterial filter is needed. We need to bring down the circuit level and all those things. It is the current update in the pediatric perfusion strategy. Coming to the cannulation. Initially, in all type of pediatrics, we think that the cannulation is only possible through aorta or SVC, IVC. But now, in latest trend, we have all the technology has helped the research and development is in a higher way where we are getting cannulas, which is coated too. And also the cannulas are modified in such a way that all possible cannulations is appreciated. The drainage is not compromised. The cardioplegia delivery, even we have a pediatric cardioplegia, antegrade, retrograde, all are possible in the current trend. Venting, as I see that maybe 20 years before, the smallest vent will be a 16 French vent, while the heart, the 16 French will be the size of the venous cannula for a pediatric case. So I would like to say that the technology has developed. Even we have six French vent cannulas and suction devices, bullet suction with multi-hole, and all those things are possible in the current update. As I was discussing initially, now the cannulation in pediatrics is wide open because the cannulas or the aortic size is much smaller in the pediatrics, and I have seen in my experience saying that the cannulation was even done wrong, where we always tend to have an underdeveloped heart, where there are a lot of techniques where you will have a PDA over there which connects your aorta and your pulmonary artery. Without snugging, then it is going to have a recirculation over there, and you can even cannulate the PDA for going on pump and before ligating, or you can ligate and then go. All such updates are available for discussion. So I would like to show here that we have the possibility of cannulating the ascending aorta. If it is a TGA, the aortic size is going to be much smaller than your PA. So, but we have cannulas for that too. And if you have a hypoplastic LVH or a syndrome where the pulmonary artery needs to be cannulated, it is also possible. And dual cannulation for interrupted aortic arch. And after the repair, it can be with single cannula, we can proceed with the surgeries. And all such updates are available in the current trend. And also the most important thing for a perfusionist is the venous drainage. And as I can see that the routine SVC, IVC cannulation has been developed, and even interrupted IVC, because there will be an azygous flow, it is also needs to be taken care of. And for a deep hypothermic circulatory arrest, if the cannulation is really tough, a single RA cannula, cool down the patient and then proceed with the surgery. And all those updates are still available, and the cannulas the selection of cannulas is important, and it is updated to the current level. Thermal management. If I ask you which is the best way to do, already there was a presentation which clearly explained already by the first presentation, where the neurological monitoring was discussed. So if I ask you which is the best mode of stat which you need to follow, I would like to emphasize before discussing on that whenever you see, these are the most important things which should be flashing on your mind. Your flow should never be compromised, whether you're going to be using a pH stat or an alpha stat. Why? It is because it is the only way of oxygen delivery. Yes, I agree that during hypothermia, the metabolic needs of a patient reduces. Every 6 to 8 degrees in decrease of temperature is 50% reduction in your metabolic need. But still, your flow needs to be constant, because on alpha stat, the dilution of the gas are higher. And that's why your pH goes in a higher level, while your PO2 and PCO2 is decreased during hypothermia. How will you know that? You will know by doing a ABG, VBG, or online monitoring devices, which shows your DO2, your regional oxygenation. All these things plays a vital role. And this is what we talk in GDP. Hypothermia is the most common strategy which is followed in pediatrics. And you need to know that what physiological effect a hypothermia can bring in. So as we all know, how does the pH goes high? Because the ATP molecules which is stored over there, as the dilution increases, the PaO2 level has decreased and PCO2 levels are decreased. So the proton molecules are released higher in the blood cells. And that is the reason the blood tend to be alkalotic during hypothermia. And that is why we also prevent calcium in your prime, and calcium also has to be reduced as much as possible. And that is why we always see there is a raise in your lactate level in your pediatrics. And this is the reason for it. And cooling down and rewarming should be gone slow, and maintenance of temperature either way plays a very important role. So I would like to say that whenever you practice in a pediatric perfusion, a combination of alpha stat and pH stat is the better choice. While cooling down, you go with alpha stat, where by making sure that while cooling down, you go ahead with pH stat, that is by increasing or decreasing your sweep gas so that you maintain your CO2 to a normal level or bit on a higher side for your neurological protection also, while you can have a uniform cooling. And while you go down and attain your desired temperature, then you can switch over to the alpha stat and go on. So by that, it plays a very good management of your pediatric cases. Myocardial protection is also very important, as we all know. I would like to say that neonates are still requires hypothermia and hypokalemic arrest. So how it is followed, it is usual that the regular cardioplegia technique which we are following worldwide. But one thing which I would like to emphasize here is we have two types of cardioplegia which is available in the market, and that is the update, which we know that the HTK solution, which is very commonly used for a single dose for a longer period of still heart. It is mainly used for transplants, and I have personally used these HTK solutions for pediatric cases, which gives a wonderful outcome for switches, double switch, and sendings and as such cases. And the main cons over here, what I can say is, if at all the surgeon needs to repeat the cardioplegia, so that is when we can see there is a lot of arrhythmias, there is a disturbance in your electrolytes, and hemodilution is very high because it is completely crystalloid, and the chances of myocardial edema is also higher because adding mannitol to your cardioplegia is again a debate here. The extracellular solution, as you all know, it is St. Thomas and your Delnido, which is very common. Everybody knows it is 4:1 and 1:4 ratio. And pediatrics especially, Delnido is widely used in the current update, and it is because of it has lesser calcium and magnesium. So that is one thing. And it is the low glucose hypopolarizing crystalloid solution, which is delivered in a reverse process of 1:4, had an arrest and also in a better way of better myocardial protection compared to others. And again, it is an institutional protocol. So whatever protocol your team decides, and that is the best way to go along. And only idea which I can update you, saying that a single dose cardioplegic technique is much appreciated in pediatrics, while multi-dose interrupted surgery cardioplegic. Cerebral protection, again, there are a lot of things which has been discussed before. I would like to enlighten a few things over here. We have developed neurological monitors, which tells us how good is your perfusion. So cerebral oximeter, NIRS, which is a real time, which is also used to know your regional perfusion, how much is your oxygen delivery, how good is your oxygen delivery, whether your PCO2 is related to your flows, whether the brain is getting adequate, or there is an alarm saying that you need to increase your flows or you need to check your hemoglobin, and all those things are vital in pediatrics as well. And the update here is we have the neurological monitoring devices, which is an online or an inline device which can be monitored throughout your pump run. And of course, bispectral index, which also shows the level of anesthesia. We can say what is important. It only tells the level of anesthesia, but the level of anesthesia is decided by the flow rate which you are flowing. So if at all it goes down, and it is an indicator for the perfusion or how much we are flowing. So as we discussed a lot, and if you ask me, what do you say as the safe technique or safe strategy for an hypothermic circulatory arrest or a profound hypothermia or a deep hypothermia? I would like to say pre-bypass treatment of steroids. First of all, you need to have a strategy for it with your team. And secondly, your hyperoxygenation, which means you need to maintain a higher DO2. Your DO2I ratio needs to be higher. It was wonderfully presented by the previous speaker as well, but I would like to enlighten it here. And also make sure that you take time in cooling. Don't be in a hurry, and have a uniformed cooling, have a proper cooling, by monitoring all the required data, and that will help you to give a better perfusion. Maintain a higher hematocrit during your cooling phase. Use pH stat, as I explained to you before, and also this was again mentioned in the first talk, saying that you need to have an interrupted flow, cerebral flow, whether it is antegrade or retrograde, but having an intermittent flow to your brain also provides a wonderful outcome, and it protects your neurology. And judiciously using your ultrafiltration, muff or cuff, can help the patient also. As I want to wind up, I would like to say that goal-directed perfusion is the current update involving all the topics which we spoke, starting from neurological monitoring, from the regional protection of all your organs, from liver, from kidney, from lung. All those things are totally interconnected, and it can be viewed by goal-directed perfusion. What does goal-directed perfusion emphasizes on, or what does goal-directed perfusion says? It is very simple. It focuses on few points. One is oxygen delivery. Second is oxygen extraction ratio, or the VO2. The third one is the venous saturation. So how much is the venous saturation? And the fourth one is your CO2 production. How much is your CO2 production? And the fifth is your hemoglobin. And how much is your flow, whether you're flowing adequate or not. So as you can see here, these are the points which are there was a debate where Rinucci was saying that it should be more than 260, 275. And there was a Philip D. Sommer, he was telling that it is almost like 280. But the thing which is very clear is always maintain an oxygen delivery index, or DO2I, more than 300 or 350 is the best way to go on. Having a higher hematocrit, maintaining all these things plays an important role. And this is the graph which clearly explains to you that keep the patient in the anaerobic side. All the talk which was running around, if you see here, just to enlighten, keep your critical DO2 is 600. Don't get confused. This is a critical DO2, which is ml per minute. If we talk about DO2I, it is a delivery of oxygen index. Then we call it across oxygen delivery by your body surface area. and that is DO2I, where this graph shows the DO2. So keep a higher DO2, which is more than 600, and focus that your patient stays in the anaerobic side. What happens if you do so? Your SVC, you can see it is more than 70%, and your VCO2 level is also in the desired level. And if you can compare and see that your oxygen extraction ratio, that is VO2 by DO2, if you do so, that is nothing but maybe around 600 by 200 or 250. If you see that, that level is also, it comes almost like 25 to 30. It is very simple. If your SVO2 is 70%, the rest 30% is being absorbed by your tissue. So we need to maintain that in a proper way. So as to conclude my talk, I would like to say that the approach now is goal-directed perfusion, and we all have updated gadgets to monitor and to fine-tune ourselves to render a wonderful perfusion or the best perfusion practice, which can help the patient and also to help the team to have a wonderful and a successful output. And there are researches on safety and efficacy, what is a novel CPB technique, and all is going on in the world. And as a perfusionist, as a perfusion scientist, we need to keep ourselves updated to accept our knowledge and to upgrade ourselves so that we can render the best to the patient. Thank you.